Okay. Hello, everyone. Good to be here. Let me first start by extending my thank you to Marianne Goodman for inviting me to do this presentation, and also to the rest of the planning committee. It's been a great conference, actually. So let me tell you what I'd like to do in the time that I have. I want to talk about developments in dialectical behavior therapy and my own experiences and the research that we're conducting in Toronto, and some of the developments from our experience. But let me begin with some disclosures. So I am an unpaid member of the Scientific Advisory Board of the Linehan Institute. I do on occasion receive training for DBT, so you can take what I say with a grain of salt if you'd like. In terms of what I'm hoping you'll get out of my presentation, I'm hoping that you'll be able to take away at least a summary of recent research on DBT and some idea about what the clinical implications of this research are, and also to identify some of the emerging directions in DBT, which, as I've heard about emerging directions in other therapies, are not entirely different, so this might sound perhaps a little redundant. But this is just the brief history, evolution of DBT, and I should say that I really stumbled upon this treatment largely because about 23 years ago, I was working with a really challenging patient, and a lot of the treatments that I'd learned in grad school just didn't seem to apply so well with the patient I was working with. And this was in the early 90s, and it was just shortly after Marcia came out with her first study. So I think I, like a lot of other clinicians and researchers, started getting interested and curious about DBT, and mostly I was curious about whether or not it would work with this substance-dependent population that I was working with at the time. So I was really excited to hear that Marcia was also interested in addiction. So since Marcia's early trial, probably we're all aware that there's been a rapid growth of DBT dissemination. There's now over 31 randomized control trials. 17 of those specifically focus on personality disorders. And so I decided to have my talk primarily focus on borderline personality disorder because the bulk of those trials focuses on BPD. I think one comment just about the growth of DBT, there are unquestionable barriers, and people have raised the barriers to the implementation of DBT, and that's a huge problem, which I'll discuss. And I also think that certainly the growth of DBT internationally, many of these trials cut across over 10 countries, so the growth of DBT, the practice of DBT, I think also highlights the fact that the treatment has been embraced quite widely. And this is in spite of the difficulties of implementing and uptaking the treatment. But I think there is a real thirst for learning the treatment. In terms of the directions that I'd like to focus on, I want to talk about the problem of accessing treatment. I'd also like to focus on mediators and moderators of treatment response. And I'd like to focus on the topic of integration, and that's been a theme that's come up. It was in the last theme in the transference focus panel that I just sat in. So I'll share a little bit about my thoughts about integration in DBT. So this is brief history. What do we know about how DBT impacts outcomes in a borderline population? Well, we know that it's associated with significant improvements in symptoms, suicide and self-harm, but also a range of other symptoms. We know that it's associated with significant improvements in healthcare utilization, so reduced ED visits and inpatient days and medication use, and associated with improved treatment retention. It also is associated with improved interpersonal functioning, although I'll say a little bit more about that, but there's certainly evidence that there are gains made in terms of interpersonal functioning. And although DBT has been critiqued as primarily focusing on symptoms, and there's been concern that DBT doesn't really address the personality, actually there is evidence that although DBT focuses largely on symptoms, it also addresses self-introject and really how people see themselves and views of themselves. So there was an interesting study about this. So we also know that the gains made in DBT are quite durable. from the study that we conducted, which evaluated people 36 months after entry into DBT, so after a 1-year treatment. Actually, people continue to make improvements post-discharge on most outcomes. So we also know, unfortunately, and this is not entirely surprising because we've heard this across, this is a big problem in the field of BPD, that we're not doing very well in the area of functioning. This is data from our randomized control trial. This is looking at collapsed across the 2 conditions in that trial, so DBT and general psychiatric management. And actually what we found here is this is just looking at people not working or in school. You can see very little change pre-treatment to 36-month follow-up, both in terms of their engagement in productive activities and also their reliance on psychiatric disability. So unquestionably, this is an area that we need to improve upon. We need to understand what are the barriers to people functioning. And there really hasn't been enough research trying to understand what are the barriers and how can we increase the likelihood that people are going to become more functional. There was one study by Wilkes looking at trajectories of functioning, and what she did find is that higher emotion dysregulation predicted poorer functioning, and it also predicted poorer improvements in functioning. And I think it's important because I think it does highlight that the inability to regulate emotions simply seems to be a barrier to the acquisition of employment. So what do we know about DBT compared to specialist treatment? So these are findings from our study published in 2009, and the follow-up was published in 2012, DBT compared to general psychiatric management. And what did we find? Both at post-treatment and at 36-month follow-up, there were no differences across any outcomes. Both treatments did very well across a broad range of outcomes. There were no differences in treatment attrition. So what can we conclude? And since I have the podium, I think I wanted to take an opportunity, I think, to comment on this trial because there's been some misconceptions about what to conclude from this trial. And I think one of the misconceptions that's carried forward, or something that I've heard a lot, is that this means that DBT is equivalent to a non-specialist treatment. I've seen that written in several places. And I think it's a narrative that needs changed for a few reasons. First of all, it wasn't an equivalence trial, so that means that the study wasn't powered for equivalence. But that aside, the other, I think, perhaps more important piece is the issue of whether or not GPM was specialist or non-specialist. So in this trial, it's important to note that GPM was delivered by specialists. These were psychiatrists led by Paul Links, who's clearly a specialist in the area of borderline personality disorder. It was a team with considerable expertise in suicide, in the treatment of suicidal behavior and in the treatment of borderline personality disorder. I think the other perhaps important piece to this is that the treatment itself was a manualized treatment. It was a manualized treatment based on John Gunderson's work. John is clearly a very notable figure in the area of borderline personality disorder, so I think arguably we could say that perhaps his work is specialized. It was specialized to treat people with borderline personality disorder. I do think that what's important about the findings from this trial is that it has stimulated a lot of interest about why did we see that DBT wasn't superior. And what I think it's done is that it's really helped people get curious about what may be the common factors that cut across treatment, and that there may be multiple ways to work with people. I do think an important next step is going to be to look at whether or not, and I know there's certainly a lot of work that John and Lois and others are doing in terms of disseminating GPM. It's a different version of GPM. I think what will be important would be to evaluate what is the impact of training people in general principles in a one-day training, and how does that impact outcome. So I think that's a study that needs done. I'll be interested to see the results. And I actually think if we get good results from training non-specialists in a one-day workshop, we should be doing it. So let me turn to new directions. So this is moving on to how do we increase access to DBT. This is not a problem I think it's unique to DBT. We're all facing real problems with people being able to access specialist treatments. And I know in our healthcare setting, I'm constantly getting encouraged to be considering 6 to 8 session therapies for very complex borderline patients. I've suggested we should just go to postcards because at least there's data on the postcards. Why 6 to 8? Seems like a lot. So what are we doing about it? Well, one question is whether or not the DBT skills alone could be effective. And certainly my interest in DBT skills, and I think others, their interest in DBT skills, is that a lot of people were challenged by having long wait lists, having difficulty implementing a comprehensive program. And so intuitively, it seemed that probably the skills could be useful, or how could they be harmful? So why don't we look at the effects of skills only for people with borderline personality disorder? There's now 3 randomized control trials on skills. I'll put them all up at once. The top 2 are brief skills. So the first 2 studies, one was done by Solaire, the other done by myself and colleagues. One evaluated 13 weeks of skills, and the other our study evaluated 20 weeks of skills. And what we found, actually, to my surprise, I wasn't really sure that we'd get such good results, but in fact, what we did find is that brief skills were very effective. In our sample, so the 20 weeks of skills, we specifically recruited for chronically suicidal patients. So that was different than the study by Solaire because their patients weren't specifically recruited for suicidal behavior, and you can see that in terms of outcomes, really where they made gains largely was in the area of depression and anger and anxiety and affect lability. Our sample, a more suicidal sample, was making significant changes in suicide, self-harm behavior, and anger, increased coping skills, decreased depression. Linehan, you'll probably be aware, there was a randomized control trial she conducted, a dismantling study. She also was interested in looking at the impact of skills only. Now, hers was a little different. First, it was a longer-term treatment. It was a 1-year treatment. She looked at skills plus fairly comprehensive case management with case managers trained in managing suicidal behavior. And she compared that to individual therapy plus case management and then just standard DBT. But to her surprise, also, she found that first of all, standard DBT, was not superior on suicide-related outcomes, and that the conditions with the skills training was more effective than the individual therapy condition. So that was important. I think there is one key finding, though, in both our study and Linehan's that is important to take note of, and that's that there were some gains made in treatment in the skills condition that were not maintained post-discharge. So, and keeping in mind that Linehan's group and our group was a more suicidal group, so I think that we shouldn't necessarily see skills training as a panacea for the more severe population. It seems that it may be helpful for specific outcomes and certainly might be very useful for symptoms of individuals in a more acute phase. Okay, so another question is whether, and we've talked a lot about it here, is what is the appropriate dose of treatment, and how do we know what dose of treatment? There's almost no data on dosing. So I wanted to share with you just some details of a study that's underway in Toronto. So this is a study I'm conducting with colleagues of mine, Alex Chapman, Janice Kuo, and others. And this is a randomized control trial. We're evaluating the clinical and cost effectiveness of standard DBT in a 6-month form as compared to a 1-year form. So our interest, we've actually powered this for equivalence because we believe that 6 months will be equivalent to 1 year. And the reason for that is when we looked at the data from other trials, most of our clients are making gains by 4 months into treatment, and then they maintain those gains. We don't really know whether or not the extended treatment to a year is necessary to maintain gains, and this is part of our interest. So A second goal of the study is to try and discern who would benefit from briefer and who actually needs a longer format. So our projected sample size is 240 clients. We currently have 200 people enrolled and will be completed enrollment. I'll be very happy and crack open some champagne by early June when that happens, but at least they'll all be enrolled by June. So by hopefully later next year, we'll have some data on the results of this. So what can we take away from just the clinical implications of abbreviated versions? I think from the skills-only studies, I think in the absence of comprehensive treatment, I do think brief treatment, brief skills can be used to address more suicidal, complex group. And I think that's been a question. There's been worries about doing DBT skills with a suicidal BPD population, but I think we found that it could be effectively used. I do think it should be considered an adjunctive treatment rather than a standalone treatment for severe BPD. In terms of what can we conclude about dosing, well, we don't really have much yet to guide us around decisions around dosing. So let's consider another topic which is of interest to me, and I know others here. It's like who responds. And this is important, and again, it was raised in the last panel. We know that in randomized controlled trials, we're reporting results that are based on mean effects, and we don't necessarily have everybody responding in accordance with the mean. So we know that the mean effect is going to be an overestimate or an underestimate for specific patients. And we know that the variability of treatment response is going to be a function of the potency of a particular treatment, the characteristics of a particular individual, and whether there's a match between that individual or whether there's a mismatch between the individual and treatment. So I think an important question is to figure out who's going to respond to the treatment and who doesn't respond. And there's a variety of ways to look at this, some very interesting ways. And one approach that we've taken is to look at trajectories of response. So specifically, we were interested in looking at whether or not there are different responses and maybe subgroups, some who respond and some don't. So interestingly, we did find that, in fact, there were 3 different groups. We used latent class growth mixture modeling. And actually, the largest group, which was somewhat encouraging to see, about 84% were labeled rapid and recovered. So this is the bottom blue line. I don't know how to use this, so I won't. But it's the bottom line. So those are people who seem to do well, and they continue to do well. And that's the vast majority of people. We have a small group, so the very top blue line. You can see that actually they're quite slow to respond. So during treatment, they may look like they're not actually making many gains, but by 36 months, so post-discharge at this point, they've done reasonably well, although you wouldn't necessarily have predicted that based on how they're doing during the treatment phase. And then we have this other group, another small group. It's about 8% of our sample. And I should highlight something I didn't quite say here, and this is important, but this sample was based on our DBT versus GPM randomized control trial. So it is collapsed across condition. However, we use condition as a predictor of the subgroups. I'll get to that. But what we did find is that we've got about 8% of our group of 180 people that actually show that they've made fairly rapid gains during treatment, but actually post-discharge, they don't maintain those gains. So now, interestingly, who are they? Well, what predicts this relapsing group? These are individuals whom at baseline had higher levels of depression, they had higher rates of emergency department visits, and employment was another predictor of relapsing. And I think, if I can try and explain why that may be so, I think it's entirely possible that this subgroup may be more isolated, more dependent on healthcare utilization, and that when they start DBT and when they're in DBT or GPM for that matter, it provides a holding, so to speak, but when treatment's removed, actually they don't maintain those gains. And it may be that part of the problem is that neither of our treatments were doing a very good job of actually helping people deal with their sense of isolation and dependence on healthcare utilization. That's just a theory to be tested, but okay. So what do we know about who drops out? There are a few studies that have looked at characteristics of dropouts from DBT. So we did a study in our lab. Again, this was based on our randomized control trial. We found that people who were more likely to drop out had higher levels of anger, had higher levels of Axis 1 comorbidity, had more suicide attempts, and interestingly, and in fact, the strongest predictor of dropout, not entirely surprising, was poor alliance. So early alliance, and we had people rating the alliance on the Working Alliance inventory over the first 4 sessions, was our best predictor of dropout. There's another interesting study that Anthony Rocco led looking at, and I think it's interesting because it highlights that neuroimaging holds promise for isolating really markers of brain function that may predict attrition. And in this study, what was found is that non-completers or dropouts showed less activation in the dorsolateral prefrontal cortex during response inhibition. And it may suggest that sort of improving behavioral control, response inhibition is potentially relevant to engagement in therapy. In terms of what are the clinical implications of these studies, I think that there's no question that deficits in occupational social functioning seem to be a core factor associated with treatment response. There's been discussions about prioritizing that for treatment. There's also been a lot of discussion about when to prioritize that. I know that in the TFP panel, there was discussion about extending the treatment to 18 months in order to prioritize a focus on functioning. In DBT, Kate Comtois and her group has been talking about DBT with an addition of an occupational focus in the treatment. However, the treatment is 2 years in length. I would argue, and this is something to be addressed, is that actually perhaps we need to start from the beginning, and that actually may be key to enhancing treatment outcomes rather than sort of waiting until people are more stable. But actually I think it may be a key piece to increasing decrease of symptoms. Other things that I think we can take from these studies is that no question we need to do a better job of strategies to target isolation potentially and barriers to functioning. And that it may be that retention is going to be improved by better strategies, in particular with those with more severe profiles and those who likely have more distrust and more difficulty engaging in relationships. So we may need to sort of beef up or strengthen our strategies, in particular for that particular subgroup. Now, what do we know about how DBT works? And we've heard from a few people, I think that this is an area that's been lacking, but it's an area that it's emerging. And I think it's unfortunate we don't have more information, since this will guide us on how to improve the effectiveness of treatment. I should say that perhaps before I even just put that up, I'll take that off. But, we assume that DBT works by addressing emotion dysregulation, behavioral discontrol, and we assume that it's within the context of a very strong therapeutic relationship, that if we use strategies like acceptance and a change-focused approach and dialectics, that they're going to exert their effects on outcomes. And I would argue that I think that we assume that by using these strategies, we have the impact on outcomes through several mechanisms. And the mechanisms I'm going to highlight here are the mechanisms that have received the most attention in the research. So increasing awareness and acceptance of emotions, attentional control, emotion modulation, and coping skills are areas that have received attention. I'll say a little bit about some of the research. So we've done some research, and this was looking at changes in emotion and also cognitive problem solving, and we found that actually increased emotional balance and problem solving were both associated with better outcomes. However, interestingly, emotional balance was independently accounted for better outcomes, and that was even after controlling for therapy alliance. So it highlighted the importance of balanced emotions. There was some research looking at increased attentional control and found that that mediates treatment outcomes. Some research that shows that the more time people spend practicing mindfulness, the number of minutes spent in mindfulness, time engaged in formal mindfulness was strongly associated with better outcomes. And there's also evidence that just the increase of use of coping skills is a mediator of symptom improvement. Now, there are a few studies that have looked at how the brain changes in DBT. There's actually 5, or I heard one this afternoon that's not published, but there's at least 5 neuroimaging studies have explored brain activity with DBT, and the studies show that positive outcomes in DBT seem to be associated with particular areas of the brain. So there are neural underpinnings, it seems, connected with positive outcomes. So what do we know? We know that actually DBT seems to be associated with reduced reactivity. So Marianne Goodman, where is she? There you are. Your study showing that the decreased amygdala hyperactivity, and there's some other evidence showing amygdala normalization is associated with more positive outcomes. There's also evidence of downregulation of the limbic system. There's also evidence that shows that DBT outcomes, positive outcomes, are associated with the inhibition of responses, so increased activity in the dorsolateral prefrontal cortex, increased connectivity in frontal circuits, so medial and superior frontal gyrus, and also activated anterior cingulate cortex. I've got the references for all these. I've just summarized across these studies to just give you an idea of some of the work. But I think, in short, what it seems to indicate is that DBT does seem to be associated with the downregulation of limbic hyperactivation, and it also seems to be associated with the enhancement of brain regions associated with cognitive control. So what are the clinical implications of studies on mechanisms? I think first, an emphasis on strategies to increase awareness and acceptance, in particular of positive emotions. And I would take that from, in part, some of the research that that I highlighted earlier about balance. It wasn't so much about decreasing the negative emotions. Actually, it was about increasing positive emotions that seemed to be key. And I think this is important because, especially when you consider a lot of the clients we work with who often fear and dread positive emotional experience, or at least I hear a lot of comments about that. Enhancing attentional control also seems to be critical to positive outcomes. So increasing time spent in mindfulness practice, for example, is one way. There's probably other ways to do that, but that seems important. I think just educating people about how the brain changes in DBT. So this is something that clinicians may not do, but in particular, clients who may be skeptical or uncertain about the benefits of talk therapy and perhaps gravitate more to medications because of their belief that that would be more potent in terms of changing their brain. This might be important to do. And just also practice strategies that strengthen neurological deficits related to emotion regulation. And Harold, you were citing a study yesterday in that regard about how, I think it was about distraction, was it? Was potentially a way to do that. And just teaching coping skills seems to be something that we should be doing more of, since it does seem to be a key mechanism in DBT. Now, the next or the final topic I want to talk about is how do we improve DBT, possibly through integration. And I think integration well, let me take a step back. I think it's important for all of us to look at what are the limitations of our model and to figure out how can we address those and ultimately enhance the effectiveness of our treatment. Certainly the idea of extending by integrating elements from other models isn't new. No doubt there's lots we can learn by cheating off the next guy. So let's look at what are we doing in this area. Actually, treatment of BPD and PTSD has received the most attention. So we know PTSD occurs commonly in BPD, about 50%. So there's some research focused on what the limitations of standard DBT have been. And in fact, study by Harned, that's the second study here, found that the co-occurrence of PTSD and BPD in treatments for DBT showed that actually people had poorer outcomes than those with BPD alone. What we found, actually, a similar study, we did find that really your folks with PTSD and BPD, they start off more severe. Their rate of improvement is comparable to the non-PTSD group. It's just they start off more severe and they end more severe. So it seems something is needed to enhance the effectiveness of treatment for them, not because their response is slow, but rather they just have more severity. There's more to be addressed. So Melanie Harned and her group and Martin Bohussen, his group in Germany, have done the most work in this area, and they've been integrating standard DBT with prolonged exposure. And they've done it slightly differently. The German model is, of course, to do it in the context of inpatient treatment, so they're taking people who are probably higher suicidal risk because they can manage that in the context of their inpatient program. Melanie Harned's group is doing it as an add-on to standard DBT, so it's in addition to regular DBT sessions, weekly sessions, but it's offered on an outpatient basis. And what this means is she won't take people into that protocol until they've had at least 2 months of not engaging in suicidal and self-harm behavior. But in short, I think what's been really important about this work is that the findings indicate that actually you can actually not only effectively treat people using prolonged exposure and DBT, but your outcomes are going to be better. And this is important because there was for a long time a belief that you had to stage treatment so that the treatment of the trauma had to occur well after the treatment DBT was being conducted. But what Harned did find, and Martin's results aren't so different, is that actually the majority of people prefer the combined treatment. So that's important. What Melanie found is that actually the rates of remission in PTSD were very comparable to other PTSD treatments. The treatment was associated with large improvements and a variety of BPD and trauma-related outcomes. So I do think what's really important about this study and this work is that it does highlight that it's important to target both of these issues. Now, turning to another issue, and that's just looking at what are just other limitations of DBT. And so this is an area that I always feel risky talking about. I remember Marcia once told me she was talking about the problems of DBT, and then she saw quoted everywhere, DBT has big problems. But I think it's important. I think we all, we need to put out everything, and we need to look at what are the problems. And I think I say possible because we don't really know if this minimizes the effectiveness of the treatment. But there's no question that DBT, like other therapies, focuses on a specific level of analysis of behavior. In DBT, we're largely focused on emotion and behavioral dysregulation, and that's prioritized over other domains of psychopathology. It means that we're focused on assessing and really systematically assessing emotions and behaviors and making that a focus of intervention. So the question is, could we improve ourselves by systematically analyzing and incorporating strategies that address other domains that are not prioritized in DBT? For example, could we do a better job of really analyzing problematic relationship patterns? And mentalizing deficits. Certainly social occupational functioning, no question. So these are questions. There is actually one study that I've seen. There's a lot written theoretically. Well, I shouldn't say a lot. There's a couple of reports written theoretically about the integration of DBT with other models. But there's one study I found looking at DBT integrated with mentalization therapy. And basically, this was a pilot study, so it involved inpatients with BPD. And actually, what the study showed, and essentially this study, I should explain, included mentalization group therapy with standard DBT versus DBT alone. And the findings of the study actually indicated that both the DBT plus the DBT enhanced with mentalization didn't do any better on symptoms. But what the study also indicated that the DBT enhanced with a focus on mentalization was superior in reducing fearful attachment and improving affective mentalizing capacities. So it could be that combining DBT with some other strategies that are not prioritized actually may make the treatment more effective, in this case, particularly in the area of attachment security. So what are clinical implications of DBT integrated with other models? I think the first implication is that standard DBT unquestionably should be strengthened by targeting trauma for BPD and PTSD. That's assuming that's what the client actually wants to do. I think there's evidence, preliminary evidence, that DBT can be enhanced by strategies from mentalization-based therapy. I want to say here, though, I do think more work needs to be done about who might benefit from the pure form and who might benefit from an enhanced form. So I don't think we should assume everybody needs an enhanced form. There's certainly research in other populations. I'm thinking generalized anxiety disorder, where people have enhanced CBT with other models, in particular interpersonal interventions. And actually that work has indicated that it's not necessarily that enhanced treatment is required for all patients with GAD. Only particular types of patients, in fact, it was dismissive patients with GAD, benefited from an enhanced treatment that had a focus on interpersonal interventions. So we need to better understand who might an enhanced treatment be best for. I think best practices does support at this point still evidence-based therapies for BPD, including DBT. We don't, at this point, have evidence for demonstrating the effectiveness of therapy based on an integration of common factors. So my take-home is that don't drastically change your practice. I mean, stick with what we know works. But I want to comment on the whole topic of common factors. And you know, over the past century, people have been talking in the field of psychotherapy about common factors, and I think it's very important that this is now a focus of conversation in the area of therapy for borderline personality disorder. I do think that we need to better understand what common factor, whether the common factors are actually related to treatment outcome. I also think that we need to think about how do we put common factors together, because we could collect a lot of common factors, but it's not necessarily that there's a cohesive theory to contextualize those factors. So collecting common factors is somewhat atheoretical, and I think we have to figure out how the factors can shape and inform and the development of a theoretical model, or whether that may even be necessary to do. So just something to be considered. So where do we go from here? Well, I think that we need to look at how to increase the availability and optimal delivery of DBT in routine settings. I think we need to understand better what's an appropriate dosage of therapy, or how to even make, we need knowledge to inform how do we allocate perhaps people to different doses. It may be that some people would experience a short-term treatment as quite harmful, and some people actually may require a longer format. And I think in the absence of knowledge about appropriate dose, I think it's really hard to make informed decisions about how to allocate patients. I mean, I think it's an issue that I know I struggle with as a clinician. How do we decide who gets the longer treatment and who gets the shorter treatment? And it may be that actually shorter might be harmful for some, or maybe exactly what's needed. So I think this information could also inform us about even how to set up an evidence-based step care program. We need more studies on moderators change, because I think that will advance the aim of how to personalize therapy. So more is needed in that regard. More information about the mechanisms of action in DBT, but for that matter, across all therapies, because I think if we could better understand the mechanisms, we could potentially strengthen the effectiveness of our treatment. And finally, I think we need to, and perhaps I've said a little bit about this, but I think we need to consider the relationship between common factors and treatment outcome. I also think we need to consider whether there may be unique factors within each model that contribute to outcome. And finally, I think we need to consider whether or not there may be factors within all of our treatments that are potentially harmful. Because we may all be doing certain things, but we don't necessarily know whether they're helpful at all and could potentially be harmful. So on that note, thank you. Sure. Yes, Valerie.
I remember when I first met Marsha, she was trained in DBT. She talked about a period of time before treatment began where you would kind of orient somebody to treatment. And when I meet people with fall-on personalities or who drop out of treatment, they kind of feel like they're in a crisis and they go to DBT and they don't know why they're in there with skills and diary cards. So I'm just wondering whether an important thing might be to do a psychoeducation component before you start. It's something like what Paul Gilbert does with compassion focused therapy. You're born with a tricky brain. And so on. Do you ever consider that as a way of motivating them to stay in?
Certainly, I know of a lot of programs that do have a psychoed component. In fact, many programs do. I don't know of any data looking at that, but actually a lot of people are having a psychoed component largely because it helps to at least reduce or impact our resources. No, resourcing actually, because if you spend a lot of time explaining the treatment and instead you could have everybody in an education session, it may just be more efficient way. Yeah, I think it's an empirical question whether that would help to reduce dropout. I'm not sure. Yeah, Harold. Oh, can I take one more? Okay, Harold, you get a question. Okay, yes.
I want to come back to enhancing DBT for PTSD, patients with PTSD is an issue.
Yeah.
So prolonged exposure therapy is a very stressful treatment. I have patients in this treatment, and a lot of people drop out, and it's exceedingly stressful, as you can imagine. There's another evidence-based treatment for PTSD called cognitive processing therapy, where people are using cognitive techniques to discriminate between current situations and post-trauma. That seems to actually fit more closely with the kind of DBT model. It seems like it might be less stressful, so I think it might be an interesting treatment to look at as
Yeah, you know, dropouts have not been a big problem in either of the trials with Melanie Harned. However, do I think that prolonged exposure would be, one would be better than the other? I think there may be multiple ways of going about it. I mean, I'm thinking cognitive reprocessing, emotion-focused therapy, actually, and prolonged exposure. They're all very compatible with DBT, actually. But point well taken. Yeah. Okay. Thank you.